And thank you for keeping on time as well. So I have the pleasure of introducing next Maurice Zauderer. Dr. Zauderer founded Vaccinex in 2001 and has served as president and CEO of the company ever since. He has previously held senior faculty positions at Columbia University and at the University of Rochester Medical Center. He has served on numerous peer-reviewed study sections at NIH, NSF, and the National MS Society, and was an associate editor of the Journal of Immunology. Dr. Zauderer holds a PhD in cell biology from the Massachusetts Institute of Technology, and he will report to us about the signal study that Vaccinex conducted, and he will tell us about the results and about the lessons learned. So Maurice, the stage is yours. Please go ahead.
Thank you very much, Ralph. I'm very pleased to have this opportunity to review with you what we believe was the key finding of the signal trial, which was that treatment with papinimab, our anti-SEM4D antibody, slows or halts cognitive decline in Huntington's disease. I will also attempt to explain why we are unable at this time to come to a conclusion regarding other effects of treatment, in particular on motor activity. So this is a forward-looking statement, which I believe is no doubt familiar to you. And here's a very simple outline of the study design. So we had two cohorts. The first cohort included 179 subjects with early manifest disease. These were people who were diagnosed with total functional capacity 11 to 13 at baseline. Everyone had CAG repeat lengths of 36 or greater, and were randomized 1-to-1 drug to placebo and treated for at least 18 months. There was a second cohort of late prodromal patients. These are individuals who had diagnostic confidence level 2 or 3, and again had CAG repeats of 36 or greater. And I will be referring to some observations we made in that cohort, but in general, let me say that there were minimal treatment effects in the prodromal population, and we'll be mostly concentrating on the early manifest population. And so let me move on to what we thought was a key outcome. When we went to the regulators, we had proposed the Huntington's Disease Cognitive Assessment Battery Score as the primary outcome of the study. The regulators had some concerns that by taking an average of 6 different Z-scores to calculate this composite, we might overweight some outcomes and obscure the contributions of others. And so they recommended that we use a small cognitive family of 2 assessments without the use of Z-scores. And we complied and chose one-touch stocking and pace tapping, which are 2 of the 6 HD-CAB assessments, to form that family. However, we continue to believe that the HD-CAB score, composite score, is an important outcome, and so we retain that as a pre-specified exploratory analysis. As it turned out, the 2 individual assessments, OTS and PTAP, as you can see in the lower right corner, came close to significance, but not quite. So one-sided p-value was 0.028 for OTS, which just misses significance, which would be 0.025, and PTAP was a little bit higher than that. However, looking in the center panel here, which was the outcome of the HD-CAB composite, the blue line represents the patients who received papinimab, and the red line, the subjects who received placebo. And you can see that at every time point following baseline, the subjects who received papinimab performed better than the subjects who received placebo. In fact, the subjects who received papinimab never dropped below the baseline cognitive assessment. And so this was very encouraging, was particularly encouraging because the p-value here is very strong, 0.007. And so let's consider, why is the p-value so much stronger for the composite than for the individual scores? And so for that purpose, I think it might be useful to look at each of the individual scores that are average for the composite. And these are listed here, again, for the early manifest population. Please focus on the column on the right, which are the one-sided p-values. And you can see that, as we anticipated, OTS and PTAP had the most favorable p-values, and then the other values are not as good. However, please focus on the sign in parentheses immediately to the right of the p-value, which is either a plus or a minus. This indicates whether the direction of change between papinamab and placebo is favorable for the patient in terms of the outcome. And you can see in every case, it's a positive. So all of these scores moved in the desired direction, indicating a more favorable outcome of treatment. And this contributes importantly to the final p-value, because when you take the average, since they're all going in the same direction, they reinforce each other. They don't cancel each other out. The variance between the composite and the individual scores is very close. So there isn't much difference in the variance. What's different is the least square mean difference between papinamab and placebo, which is greater when you look at the composite than when you look at any individual score, and that's why the p-value is greater. This may be helpful to look at a contrasting result. This chart shows you the same data for the late prodromal population. And so again, looking at the right-hand column, you can see that the p-values are much less favorable now, and the sign in parentheses is kind of randomly either positive or negative. And so these scores would tend to cancel each other out, result in a very small least square mean difference, and accordingly give actually not a meaningful p-value of 0.9. And so having analyzed this data, we also did some sensitivity analysis, for example, to address the concern that we might be overweighting some factors. We looked not only at the full 6-item composite, but we omitted the best performing item, the OTS, and calculated a 5-item composite, and that still gives you a favorable p-value of 0.018, which is significant. In fact, even if we drop the top 2 and calculate a composite for just 4 scores, we still get a p-value of 0.046, which is a strong trend, even though it just misses significance. So our conclusions are that the HD-CAP components that assess different cognitive domains did not contribute equally to the composite score. The relative contribution is likely dependent on stage of disease. And second, the composite score is a sensitive measure of the overall direction of change in all 6 components. This adds information that is not available from individual scores, and as shown by sensitivity analysis, allows the composite to be relatively independent of a single dominant component. And so this was, we thought, very encouraging. We had some other assessments that had a relationship to cognition. In particular, we also looked at the problem behavior assessments. And this was, again, a predefined exploratory outcome. The total score for problem behaviors was not significant. However, there have been several HD studies that suggest that among the behavioral measures, apathy severity correlates best with disease progression and also correlates with cognition or cognitive decline. This was pointed out to us by Sandra Kosick, who was a clinical investigator in the study, and at her urgings, we analyzed the apathy severity score as well. And so this data is shown here in 2 pairs of bars for month 11 and month 17 of treatment. In each pair of bars, the bar on the left represents placebo, the bar on the right represents the patients treated with papinamab. Any shade of pink or red indicates patients where some degree of apathy was detected. White indicates patients in where it appeared that apathy was absent. And the way we analyzed the data was we looked at the proportion. So this is kind of a dichotomous analysis of the difference in proportions for apathy absent versus present. And the p-value at month 17 is 0.017. So that was a significant difference. We found this encouraging because it's consistent with the cognitive benefit that we had observed in the other outcomes. We also looked at the 3 other most prevalent problem behaviors in Huntington's disease, namely depression, irritability, and anxiety, and none of those p-values were significant, although depression does suggest a trend of significance, and that makes sense because there is a correlation between apathy and depression. The regulators, of course, wanted us to support the clinical meaningfulness of HD-CAB as a measure. And we elected to use CGIC, Clinical Global Impression of Change. We chose this because we were comfortable relying on the judgment of a skilled and experienced physician who has been following the patient for 18 months, or at least 18 months. And so again, this displays the data in pairs of bars. Now, let me first indicate that looking at the entire intent to treat population, there was no significant difference between treatment and placebo. However, we stratified the analysis by TFC at baseline. So on the left, we're showing the patients, the subset of patients who had a TFC 11 at baseline, and on the right, the subset of patients who had TFC 12 and 13. The thinking here was that TFC 11 indicates somewhat more advanced progression in those patients, and we were testing the possibility that our drug has an impact at a later stage of disease rather than very early, which would have been represented by the patients who had TFC scores at the top of the range of 12 and 13. And indeed, if you look on the right, you can see that the pairs of bars, there's really no discernible difference between placebo and papinimab, either at month 11 or month 17. But that starts changing pretty clearly if you look at the subpopulation of patients who had TFC 11 at baseline. And now you can see, first of all, the white portion of the bar indicates the proportion of patients who did not change during the 18 months of treatment. And there are clearly, if you focus on month 17, there are more patients who did not undergo any change, did not worsen or improve for that matter, who received papinimab than in the placebo group. And conversely, there are fewer patients who worsen, that is, are either pink or red in the bars on papinimab and who worsened on placebo. And so this went in the desired direction and suggests that stage of disease is an important variable in the treatment response. Now, I want to emphasize that stratifying the analysis by a measure that we think is likely to correlate with stage of disease is an interim strategy that we adopted post hoc because we did not correctly anticipate the stage of disease at which our drug might be most effective. Now, we may adopt this as an inclusion criterion in phase 3, or we may simply broaden the range of TFC enrolled, for example, enrolling patients from TFC 8 to 12 rather than just TFC 11 to 13. But it did lead us to consider other ways in which we might stratify data. In particular, since cognition appears to be such an important outcome, we had baseline values for the Montreal Cognitive Assessment for the patients. And so we looked at stratification of the analysis by MoCA, Montreal Cognitive Assessment. Now, this is the highest score on the scale is 30, and subjects who score between 26 and 30 are considered normal, and then less than 26 is considered to reflect some level of cognitive deficit. And if you stratify the analysis on the right, you can see the patients who were at MoCA scores of 26 or greater, and there's a very little minimal difference between papinimab and placebo treatment. However, if you look on the left and you focus on the patients who had MoCA scores of less than 26, now there's actually a very striking difference between the two. In fact, this is even better than what I showed you earlier for the total intent to treat population. So you'll recall that was highly significant, p equals 0.007. This is even better than that. There's very good separation between the error bars. And so this also reflects the stage of disease at which patients are most responsive. And interestingly, we also looked at total motor score here. And again, on the right are the patients with MoCA 26 or greater, really no difference whatsoever in treatment and placebo. But if you look at the patients who already have some level of cognitive deficit, now you start seeing a separation between the placebo group and the group that receives drug. And in this particular measure, total motor score, as you no doubt know, lower scores are better. And so this indicates, again, that treatment effects are greater in a patient population that's somewhat more advanced in disease. Now, we're not prepared to come to any conclusion from this data. This is really strictly hypothesis generating data. It was all post hoc analysis, and these are nominal p-values, but it, I think, gave us a direction for the future and a better understanding of the data that we obtained. And so let me finally refer to some of our imaging data. We had very nice demonstration of significant benefit in terms of reducing atrophy. This is a boundary shift integral analysis for the volumetric MRI. And on the left is a fairly sensitive measure of atrophy in the caudate, which of course is a region that's profoundly affected in Huntington's disease. And you can see there's a significant p-value. This is a two-sided p-value, 0.017 for reduced atrophy with treatment. And on the right, this is confirmed in what appears to be a nice trend in terms of ventricular expansion. As brain matter degenerates, the ventricles expand, and you can see there's reduced expansion of the ventricles with treatment, the blue line of papinimab. We have additional imaging data that bears on treatment effects on activation of astrocytes and microglia. We believe that a major mechanism of action of our drug is to reduce chronic neuroinflammation. And we have evidence now that SEMA4D blockade inhibits the activation of both astrocytes and microglia. And that's data that I hope to go into in more detail at another time.
Well, Maurice, we actually have to ask you to come to an end. Apologies, but we have given you 2 minutes more already. So please, if you could come to an end soon, that would be great. Thank you.
Thank you, Ralph. I'm very appreciative of the 2 minutes, and I'll close my discussion right now. Thank you.
Okay, thank you very much, Maurice. Thanks for the presentation and for the update and for sharing additional data compared to the last presentation we've seen in other meetings. So I think it will be interesting to discuss this, and obviously very interesting to get further data in the future. So I think, Dina, you will introduce the next speaker.